you for choosing this Well Chat. To support future episodes, consider purchasing a Freedom Art Mat or vegan leather journal at freedomatthemat.com. We're a nonprofit dedicated to improving the lives of women globally through wellness education and appreciate your support. Now, on to the conversation. Hey, everybody, it's Olivia with Freedom at the Mat, and welcome to another edition of Well Chat. So, today we're going back to my hometown of Memphis, Tennessee, to talk about having a hot girl summer in a well way. We have Dr. Martin Fleming, a reputed surgical oncologist at Regional One Health and the division chief for surgical oncology at the University of Tennessee Health Science Center. He's here today to talk to us about skin cancer prevention and awareness. He also specializes specifically in treating patients with breast cancer, skin cancer, melanoma, gastrointestinal cancers, and soft tissue sarcomas. Dr. Fleming has also been named one of the best doctors in America multiple times. You know, you go to your doctor's office and you see the best doctors in America. He's one of them, and he's here with us today. So since summer is upon us, I wanted to dedicate this episode to skin cancer awareness and prevention, because although many of us beautiful melanated people, we don't think we can get skin cancer, we actually can. So Dr. Fleming, how are you today? Thank you so much for joining us.
I'm doing well. Thank you. Thank you for having me.
It's a joy to have you here. When I asked the team at Regional One, I said, I need to find an expert, someone that can talk to us specifically about skin cancer, right? And they said, there's only one person. It is Dr. Martin Fleming. So thank you for joining us to talk about this episode about skin cancer awareness and prevention. So I'm aware that you come from a lineage of physicians, but I want you to tell us, what do you enjoy most about serving the world and your patients through cancer care, also known as oncology, and also specifically at Regional One Health in Memphis?
Yeah, it's such a pleasure to be part of people's lives when they're going through these kind of difficult things. I mean, it really is an honor to get to be part of that process with them and part of that journey with them. It's not a one-day event. It's often months and years of care. And that's one of the things I love about oncology is I get to be part of that process with families and help them make decisions they're comfortable with. Sometimes they're not easy conversations, and it's a real honor to get to be part of that. So one, I'm particularly pleased because of two things. One, we take all comers. I was just talking to a patient recently I could tell they were very anxious because their insurance situation wasn't what they wanted it to be, and they were very nervous. And I just said, I want you to understand, I don't care. We don't care about your insurance. We'll figure it out. We'll help you navigate it. If we can get you some, we will. But it's not going to stop your care, and it's not going to change your care. And so that, to me, is incredibly freeing as a cancer surgeon, to be able to just take care of people. That's why we go to med school. That's why we become doctors. And then within Regional One, I love the fact that it reflects our community. I, like you, love Memphis. It's my hometown. I grew up here, and my parents grew up here, and my grandparents grew up here. So we've been here a long time. And we have some unique opportunities to understand medicine and cancer care in populations of people that aren't as reflected in other cities. One of the major things I work on, we'll get back to skin cancer in a minute, one of my major areas of focus and work is breast cancer care. And so it's very clear with healthcare disparities across the United States that race makes a difference in people's care, and it shouldn't. And so Memphis is a great example of healthcare disparities coming to bear when you compare different races in the same city with the same resources in the city, so that the survival rate of breast cancer, if you're a Black woman, is not the same if you're a white woman, if you take all the stages and the same presentation. And that's just wrong. But at Regional One, we'll have an opportunity to make an impact on that. So we're actively working through the Cancer Committee and the accreditation of the hospital to bring cancer care to a level that everybody that walks in the door, regardless of their resources, regardless of their interest, regardless of their level of education or understanding, we can give them the tertiary standard of care that they deserve. So to me, it's really exciting.
No, it is exciting. I heard you say that in another interview about how really you appreciated being at Regional One, and I was unaware. Not this is a commercial for Regional One, okay, everybody? But I did find it interesting. I didn't know that you guys accept anybody, no matter if they have insurance or they don't, that you guys are really just care centric and you are patient centric. So that really said a lot to me. So as I'd mentioned, like there are a lot of girls like me and ladies who want to have a hot girl summer. I just came back from one of my vacations, so I'm super bronze right now. And while I was away, I realized something. One of my girlfriends was like, you only have SPF 30. You should have SPF 50 or 75. So I said, you know what? Let's just have a whole episode about skin cancer awareness. So I know this is one of your major areas of focus. So, first of all, are there any trends in terms of what you're seeing in skin cancer today?
Yeah. One of the major trends is younger and younger patients. It used to be a problem mostly relegated to people in their 60s, 70s, and 80s when they had lifelong exposure to sun because they were farmers or they worked outside or their activities of just hobbies would keep them outside. More and more, though, I see people in their 20s and 30s with significant skin cancers. We think it's, some people speculate, ozone depletion over time. Some people say it's changes in fashion. A lot more skin is exposed on a daily basis when people go out now than in the 50s and 60s. Maybe that's it. And then other people, we know tanning beds are a problem. We know tanning beds really increase people's risk for cutaneous or skin cancers. And so all those things I think add together to have a much younger population, which makes it really challenging and important to have conversations like this where we talk about screening and what to look for. Because just because you're 30 doesn't mean it's nothing. It still can be something significant.
I think, I'm a member of Planet Fitness and a couple other gyms, but at Planet Fitness, when I go, I'm always really curious about the tanning beds.
They have
I'm
them.
like, yes, they're there. So like when you have I have a black card, it's like instead of $10 a month, you pay 25. Regardless, you get access to this special row of rooms, and the rooms include massage chair, hydro massage, and tanning beds. And so when I come, sometimes I'll be like, I want the tanning bed. And I'm like, I'm just joking. I want that. Right. I just try to joke with them. But they have tanning beds, and I'm like, I'm always looking to see who's going in because I've never seen anybody go in.
Well, I tell you, that's a whole nother podcast. I was on American Cancer Society Task Force against tanning beds, working against tanning beds. They've now outlawed tanning beds in Australia and New Zealand completely. The country doesn't have them. It's against the law. They're bad. They cause cancer. And we have a real problem in Tennessee and the Mid-South, especially built around beauty pageants. So 5-year-olds, 6-year-olds, 7-year-olds in beauty pageants are all being taken to tanning beds so they look great on stage. And mom's putting a 5-year-old in a tanning bed to make them beautiful and bronze on stage when they're competing so they can win the pageant. It's horrible for their skin. We passed a law in Tennessee where you had to have a signed note from your parents if you were 16 or under. But Susie writes a note for Jane, and Jane writes a note for Susie and signed it Jane's mom. I mean, it's
I
if the place is not checking carefully, it probably doesn't hold up. But at least it's something. But if parents are bringing their own children, what can you do? I've had patients with tanning beds with bad melanoma problems, and they're working their way through it in their head, and they'll say things like, "What do I do with I work at a tanning salon. What do I do?" I was like, you can work there. You don't have to use the tanning bed, but that is a little bit of a conflict of interest, you know? And then I've
right.
got people that own tanning beds. They're like, what do I do with my tanning bed?
Sell it.
I said,
That's great.
I push it off a cliff. I don't know, get rid of it and give it to someone you don't like. I mean, it's bad. Get rid of it. So that's a whole other conversation. Now, women of your color at least have the benefit of a darker skin, which actually protects you. And that's a good thing. In other words, your likelihood of having skin cancer is less than somebody who's Scandinavian and blonde and blue and very fair. And the sun is much harsher on their skin than your skin that absorbs it better because you have a darker pigment, which is great. But I see melanoma, which is pigmented lesion in the skin in African American people on a regular basis. We see other skin cancers in African American people and brown toned people on a regular basis. So it can happen in any group. And so the idea of sunscreen is real important. I'm a big advocate for it. Just to clarify I'm not paid by any sunscreen companies, but I wear basically, and people laugh, my family laughs at me. I wear SPF 100 all the time.
Every day.
Pretty much. In the summertime, I had sitting on my sink, I put it on, and I mean, how much sun is too much? And I tell people, well, one cigarette isn't good for you, but it's probably not going to give you lung cancer. So is one cigarette okay? Well, no. So how much sun is too much? Well, is sun good for you? Not for my skin. So
Mm,
why do
mm.
I need any sun? And people will say, well, what about vitamin D? And vitamin D is important. We know it's important. And then I have patients that love their tanning bed and they're like, it's really important to me. And the vitamin D is really important. That's like, okay, you can get enough vitamin D in a once a day vitamin tablet that you don't need any sun for your vitamin D. So let's just
Really?
get that. Yeah. Yeah.
So going out, yeah, I mean, I need my vitamin D. We don't need to worry about that. We can get it from myself.
Right. Right. And so I
Hmm.
tell folks, don't live in a cave. Do what
Yep.
you can do. You have to have the light that brings you joy. And if you're an outside person, be an outside person. But just be
Right.
smart about it. Sunscreens work. The numbers are confusing because, you know, SPF 30 gets about 50% of the sun block UV rays. SPF 50 gets more like 97% of the rays. SPF 70 gets 98% of the rays. So even though the numbers are going up, so the amount it protects you is less. So if you're doing SPF 50, you're blocking pretty much all the sun. Back to my previous point, SPF 100 gets 99 point whatever percent. Why don't I, if I'm going to use sunscreen anyway, am I going to, why not get all of it covered? And so that's what I use. There are different types of sunscreen. And though I talk to patients all the time, they're like, what's the best sunscreen? And I was like,
Please.
well, the best sunscreen is the one you'll actually use. And everybody has preferences. So I like alcohol based, the dries kind of clear and it's not oily on my skin. So I use alcohol based sunscreens. Other people like more the lotion type and it kind of moisturizes their skin and but you have to use it. So I tell folks that have had cancer issues and have sun related cancer issues, I say get some sunscreen that you'll use. Buy 3 or 4 bottles because you need one in your golf bag. You need one in your glove compartment. You need one
Yep.
on your sink at home because inevitably you're going to get someplace and you're like, I had no idea I was going to be out in the sun waiting for 20 minutes for something. I wish I'd put on some sunscreen. Well, have it handy. And then every year you probably should replace it because it actually does expire and it quits working as well. So pick the one that suits your needs as far as what you like and like the texture of it. I would pick SPF 50 or more unless you specifically want to get sun for some reason. But I do actually surgery care in other parts of the world, and so I've spent some time in Tanzania. I've spent some time in the Philippines, and they're very close to the equator, and my skin's not made for the equator. And I wear SPF 100, and I come home without any sun, so it works.
Okay. So, Dr. Fleming, you're giving us so much without me even having asked you any questions because it's what you do for a living. Like I do this every single day. But I have a couple of questions I want to go deeper.
Sure.
So, you'd mentioned the different forms, right? So, I know about the lotion. You taught us about the alcohol based. I understand that's another type that's more of an oil. Is there any difference at all? Is it just the one that you like? Because my friend was showing me the one that's an oil, and I was
Yeah,
like,
yeah.
oh, I like that.
Yeah. I would go with the SPF number. If they have a SPF, and that's pretty universally applied now, even to clothing and makeup and other things. So, there are a lot of things with sun protector factor in it now. A lot of women's makeup, has it now, depending on if you want it or not. And then the sports clothing, a lot of that athletic wear now will have SPF protection built into it.
Yep, the golf clothes. Okay, so but let me ask you something. Can we talk about the application? Because I think a lot of women we just don't know. We just are not educated, especially Black women. We're not educated around using SPF. So should we put our moisturizer on first, followed by the SPF, or the SPF first with the moisturizer on top? What's the order?
I guess the short answer is I don't know the answer to that, but I would suspect it doesn't matter as long as the sunscreen gets on. I mean, because
Okay.
if you have oil underneath, or if you had someone that might have oily skin, the sunscreen still works. So I would say I would probably use your moisturizers or your whatever oil you want to put on first, and then put on your sunscreen. I guess if you did it in the reverse, you would run the risk of maybe rubbing off some of the sunscreen. So I'd probably do sunscreen last.
Okay.
But that would be a question for some of the sunscreen companies. I'll have to ask that of somebody.
Yeah, I'm like, if you don't know Dr. Fleming, who are we going to call? I'm like, I don't know who to call. Call who? Who do you mean call, Dr. Fleming? I don't know. So you find out and you let us know. So you'd also mentioned, which is what I've heard, there's a lot of rhetoric, a narrative that is longstanding that people who have more melanated skin, they just likely won't get it. I believe I heard a stat, or they were less likely to get skin cancer. And I believe I heard in another interview you quoted that 95 of skin cancer cases are with people who have fairer skin, even Nordic blue eyes. Is that correct still?
I think the percentage we got to be careful with, but I would say by far the majority of melanoma cases specifically and other skin cancers are sun related. And if you have skin that gets damaged by the sun, you're going to have a higher risk. The classic in the Memphis area is we colloquially use the term we're in the melanoma belt. If you look at the incidence of melanoma across the United States, there's a big swath right across the Tennessee, Kentucky, North Mississippi, Alabama area where some of the highest incidence of melanoma is. And it's directly related to populations of people that settled in that area during the, not to get too esoteric, but the 1800s, the potato famine in Ireland and what was going on in Scotland. A lot of Scotch-Irish people came to the United States. They came down the East Coast. They came across the mountains in North Carolina, and they settled in the Southeast, and they became farmers. So you have these very fair complected people that became farmers that were in the hot sun for generations, farming. And so that plays into our high incidence of sun-related malignancies in our community. The highest incidence of melanoma in the world is in Australia. And
Okay.
it's not the native Aboriginal population of Australia that's suffering. It's all the British people that left Britain or were forced out of Britain at some point, into Australia that are fair complected because the population, the native population of Britain, that's fairly far north. I mean, you're up almost like the same latitude as Canada. They don't get a lot of sun, and so over many generations of people, their skin is very fair, and they're at risk. And so when you take a population like that and you move it to a part of the world where the sun is a big part of everyday life, they're going to run into problems if they're not careful.
Okay. Thank you for that. So we're clear, right, about who can get it, which is everyone. And this also means that Black people, Hispanic people, people who have more melanin in their skin, we are not completely absolved from skin cancer. I repeat to all of our listeners, all of our watchers, you still need sun protection. So, my question of the good doctor, Dr. Martin Fleming, what would you tell Black people and or Hispanic people or South Asian, those with melanin in their skin who just really believe they can't get it? They just think it's a white person's thing. They can't get it. What would you tell them? And then what would you tell us around how we can specifically prevent it?
Yeah, I would say one, as you said, no one's off the hook. Everybody's at risk. Now, I think people with more melanin in the skin are certainly can count their blessings that they're more protected. Their incidence, their risk is lower. But I've had innumerable patients with darker skin tones that have had different types of skin cancer. So looking for the same things, having a level of suspicion if something doesn't seem right, going to the doctor, getting a biopsy if something you can't explain.
I also understand that you have the ABCs of skin cancer awareness and prevention. So talk to us about both. Like how would I know? And I can tell you, side note, when I moved to New Orleans from New York City after 20 years, I had a behavioral change. Which was I had to wear sunscreen because the sun was so much here in New Orleans. I changed skin complexions. It was a lot. I got more sunburn, but it was like I'd never been in this much heat in all of my years in New York and Chicago. So I'm like, okay, is this sunburn? Does this mean I have melanoma? Like, I don't know how to know if I've got a melanoma or a skin cancer, if I should be freaked out. And then also just kind of give us those ABCs I know that you coined, I believe, as well.
Yeah, yeah. I would say first, I get stopped and asked this question a lot. People in the hall are like, "What do you think about this?" If it's new, and it wasn't there before, so it's something new on your skin that you can go, "Oh, no, that wasn't there." Then I'd say give it maybe a week. It could be a scratch. It could be a funny bump that's going to go away on its own. Give it about a week. And if you want to put some lotion on it, kind of soften it. And if it resolves, it's nothing bad. Cancers don't go away on their own. And so if it doesn't resolve after a short period of time of kind of observing it, especially if it continues to change, get bigger, look funny, sometimes it just itches. That's actually a hint something's going on. Then it probably needs to be evaluated. Now, even with those changes, the majority of those end up not being anything bad, but you'll catch something early if you kind of use those parameters. So a lot of people have freckles and pigmented lesions scattered across their skin. Just monitor them. If they start to change or do something different, then you need to have it evaluated. For people that have lots of pigmented lesions scattered across their skin, I mean, you need a dermatologist to help you. And there's nothing wrong with a once a year dermatology visit for screening, especially if you have pigmented lesions in areas of the body, like the middle of your back, that you can't see on a regular basis. You won't know if it's changing. So having somebody look at it objectively is a very reasonable thing to do. And that's what dermatologists do all the time. And they'd be happy to help somebody screen. And some people, again, if they've had a history of sun exposure, they'll go every year or even every 6 months if they're really worried about their risk.
Dr. Fleming, to that point, who do we go see? So this issue that I'm having with my skin, do I go to the dermatologist first and then they would then refer me to someone like you, or how does this work?
I think it's important that somebody has a kind of quarterback for their care. So if they have a good primary care doctor they have a relationship with, that's where I would start. They may resolve it very quickly. Or they could do a biopsy and then send you on to dermatology if they were concerned. So a biopsy is a little in-office procedure. It's not a complicated thing. And so a primary care physician, internist, OBGYN, if they're your primary care doctor, or a true family practice primary, any of those people would be the point person if they're your doctor. But if you don't have anybody, you don't have anybody at all, you can look in the yellow pages under dermatology. They'll have make an appointment and go see somebody.
Okay. Now, what are we looking for? You have the ABCs, I
Yeah.
understand.
ABCs apply specifically to melanoma, which is a type of skin cancer that's usually pigmented, usually dark. The classic melanoma is kind of a dark black lesion that's changing. And it's tricky because that's not universally true. In other words, it's not always that. And so you can be fooled, but majority are. So we tell people the ABCs of melanoma. And again, there's a D and a E also that we add in now. A is for asymmetry. That's that strange shape that might look like a animal or the map of New Zealand or something. It's weird. It's not normally a round ovoid shape. That's a hint that maybe something's going on. B is border irregularity, meaning the edges don't stop clean back to your normal skin color from the pigmented lesion. It kind of feathers out and disappears in a way that doesn't have a clean stop. That's border irregularity. C is for color variation. If the lesion is blue and black and red, kind of all mixed in, or brown, and then that's a hint that maybe it's not a typical mole or freckle. The D is for diameter. And this is a little bit of a judgment call, but we would say if it's 5 or 6 millimeters, which is, I tell people, about the size of a pencil eraser. A pencil eraser is about 5 or 6 millimeters across. And if it's that big or bigger, then it's probably worth getting evaluated. Now, the caveat to that, though, is if you've got pigmented lesions scattered across your body, you've had them your whole life, you likely have some that are big. That's your normal. And so then I would fall back on, has it been that way for 20 years? If it has, then it's probably okay. But if it starts changing or growing, then it needs to be evaluated. And then E is, we throw in there we use the term evolution. It just means anything changing. It helps with the ABCDs to have an E. So anything that's changing, that's evolving over time, would be worth having evaluated. So things that are growing, things that are changing. For very small lesions, sometimes they might even bleed a little bit so that the surface is broken down, so you get a little bit of blood. That's a hint that probably needs to be evaluated.
Thank you so much. Got it. I was going to ask you, like, if it has like pus coming out of it or anything like that needs to be evaluated.
Yeah, 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 yeah.
So when you use the term melanoma, is that synonymous with skin cancer? Like, are all melanomas cancerous and are they all malign or malignant, or are some of them
Yeah,
benign?
yeah. It gets confusing because we also often say malignant melanoma. Well, they're all malignant. Yeah, all melanomas are cancer by definition.
Oh, okay.
And there are melanin cells are in the skin, so they're pretty uniformly skin cancers. The reality is many of the cells in your body have melanin that aren't on your skin. So it's very rare, but you can get a melanoma of the stomach or a melanoma of the colon or a melanoma, because there are cells there that have melanin in them. And clearly those are that 5%, they're not related to sun exposure. They just happen. Like any cancers, they can just happen spontaneously. And so there's no cause and effect with those rare melanomas. The majority of them, by far, have to do with sun exposure, have to do with the UV rays damaging the DNA of the skin cells and causing skin cancer.
Okay. Thank you so much. So, final couple of questions here. I've learned a lot, and I know everybody listening has learned a lot.
Yeah,
So, someone comes in newly diagnosed with melanoma. What does their care pathway look like with you? And I understand that chemotherapy isn't the only option for treating skin cancer. So, if you would enlighten us around what treatment options exist and what successful treatment looks like beyond just removing the cancer.
sure. They backing up in a very general sense. I tell patients all the time, there are only three ways to treat cancer: surgery, medicines, radiation. Those are our three tools. And not all cancers need all three. And we pick and choose based on the cancer, based on the patient, based on the stage. For most skin cancers, surgery is a primary first treatment. And then the other treatments fall afterwards, depending on what we find at surgery. And there's some exceptions to that. But in general, when somebody has a new diagnosis of melanoma, usually the first thing they need is a procedure to remove the melanoma and then sometimes check for spread with a technique that checks the lymph nodes of their immune system to see if cells have started moving around. That's kind of a package surgery, but it's an outpatient surgery, come and go the same day. It's not a massive operation, but it does require anesthesia usually. And that takes care of, by far a majority of people, that's the treatment. And then they just need follow up with routine screening of their skin with dermatology afterwards. Now, there are other treatments for melanoma. And for melanoma, the medical treatments that historically were chemotherapy are now a completely different family of medicines called immunotherapy. And people have heard the words immunotherapy in the last 10 years a lot. It's a new paradigm in how we treat cancers. And chemotherapy, in its very simplistic form, are chemicals that help kill cancer cells. They circulate around in your body. You get them IV, and there are 100 different types of chemotherapy. They work in different ways, but the bottom line is they kill cancer cells. Immunotherapy are medicines that turn on your own immune system to fight against the cancer cells. So immunotherapy has no direct effect on the cancer. It turns on your immune system to fight against cancer. And kind of a creepy concept that I talk to people, I said it's kind of a weird thing to think. We all have cancer cells in our body all the time, and our immune system takes care of them and gets rid of them. And so sometimes when a cancer has grown to the point it outstrips the immune system ability to find it, then it becomes clinically important. So we probably have a little microscopic stuff going on a lot that we just never know about because your body takes care of it, the immune system takes care of it. But if we can turn on the immune system and really rev it up, we see people with widespread melanoma cured of their cancer. So it works. Nothing's 100% by any means, and nothing's without some potential consequences and side effects. But the side effects for immunotherapy are a lot less than melanoma side effects, and the ability to treat melanoma is much better than with chemotherapy. So sometimes when people have very advanced melanomas or very dangerous melanomas, or some evidence of spread into a lymph node, even though everything else is negative, everything looks good, we talk about immunotherapy to treat their whole body and reduce the chance of having problems in the future. Medicine is the only thing that treats the whole body. Surgery treats only where the cancer is.
Yeah.
And if we use radiation, it's similar. It only treats where the cancer is. But medicine treats the whole body. So when we start worrying about cells moving around, we got to treat the whole body to make sure the cancer's gone.
Since you're so astute with a lot of cancers, right, as a surgical oncologist, I have one more question for you around. Can you advise us? Well, let me ask it differently. Is there any evidence that having skin cancer will lead to other cancers or vice versa? If you have lung cancer, you have a greater likelihood of getting skin cancer. Or you have skin cancer, you have a greater chance of getting,
Yeah. Well, I guess historically, we didn't know the answer to that question. Now we do know that there are some genetic mutations that people can have that put them at risk for multiple different types of cancer. So inherently, every melanoma patient is not maybe at increased risk for breast cancer. But if they have a genetic mutation that drives their melanoma that also drives an increased risk for breast cancer, then they could be at risk for both. And so more and more, we've been fortunate to develop a cancer genetics team at Regional One now, where we could do whole body genetics. And these are DNA, this is what you inherited from mom and dad. It gets a little confusing because sometimes we look at DNA of tumors and they're always abnormal. That's why they're cancers, but this is what you inherited from mom and dad. And if you inherit a genetic mutation, that means a gene that we all have all the time and your family is changed. And we've been able to identify over the last 2 decades more and more gene mutations that we know are associated with certain types of cancer. And probably the most common one people know about, and people pronounce it differently, BRCA1 or BRCA1, that's a breast cancer high-risk gene. BRCA1, BRCA2, everybody has a BRCA1 gene, but not everybody has a mutation in it. And so if you have that mutation, then your lifetime risk of breast cancer for BRCA1. And that's why we have, important people in the media that have undergone surgeries to remove breast tissue because they know they have that gene. And at some point in their life, they're going to get breast cancer. And so they do interventions. So there's skin cancer related genes as well, that if we start to see melanoma in multiple family members, we will test them for those genes. And sometimes we can tell them, okay, You're also at risk for X, Y, or Z. So we need to do these interventions to keep an eye out for those things because you're at increased risk. If someone's really at risk for breast cancer, you know, mammograms are really, really important. You can't skip. We really want you to get them and maybe start at an earlier age than we would normally recommend to build in those safety nets to catch things really early if they happen.
So, when you do surgery on people who've had skin cancer, what is a recommendation you have to them to prevent recurrence?
Yeah, one is stay engaged with your team, your physician. Sometimes people want to close that chapter and disappear. And I understand the impulse to have it behind you, but you'll have a team of people that care about you that want to make sure you're okay. And if they set up a every 6 month follow up or every 3 month follow up, please keep those appointments. Those are really important because if it does recur and it's found really early, it might be a nuisance and a hassle, but it doesn't become a big problem. Second thing is, those prevention. I had a patient, and it's going to sound flippant, and it's not meant to be. After her fifth melanoma, she looked at me and said, "I guess my annual vacation to the Turks and Caicos is probably not a good idea." She was redheaded and kind of freckly, and I thought, okay, I've been talking about sunscreen and I've been talking about reducing sun exposure. And she finally came to her own conclusion that would change how she acted in her own paradigm. So there are things you can do to reduce your risk as well and embrace those things. It's not about labeling you at risk and some people that's very hard. And I understand that emotionally, but you can do things that make a difference and reduce your chances of having problems in the future. And when people go over those with you, take them to heart and embrace them.
Got you. And so, as we close, this has been so helpful. Thank you so much for your time today,
Sure.
Dr. Mark Fleming. If you could leave our listeners and our viewers with one takeaway about skin cancer, what would that be?
I would say don't ignore it. Something that's changing. Don't procrastinate. Use sunscreen when appropriate. Live your life, but don't minimize the role of screening. Routine checkups, routine doctor visits, routine dermatology visits, routine mammograms. We don't know how to keep cancer from happening in most instances, but we know universally across all diagnoses, the earlier we find it, the more likely we can cure it and get rid of it, and people can move on with their normal lives. So the screening things that we throw out there as regular intervals that everybody ignores because they're a hassle, please don't ignore them. Do them.
Right. Thank you so very much. We appreciate you coming today. And for all of our Freedomettes today, make sure as we prepare for and enjoy a hot girl summer, because I know I'm going to have one too, make sure you get the sunscreen, no matter if it's oil, lotion, it doesn't matter what the form is. It sounds like from what the doctor said today, we should not do anything less than 50. So that includes me. And I've had my 30 for like 4 years. So we have to make sure that we get new sunscreen, make sure it's over 50. Doesn't matter which brand you use, just make sure that you put that sunscreen on and you reapply as you are in the heat and you're getting in and out of the water as well. May God continue to bless each and every one of you, and I'll see you at the next episode.